Welcome to Endoscopy Talks. I'm Dave Tweed from Colorado State University, and on behalf of the Translational Medicine Institute and Carl Storrs, we would like to present you our next Endoscopy Talks. So today we have the pleasure, or I have the pleasure of hearing or introducing Tim McCarthy. He will be discussing interventional cystoscopy. Dr. McCarthy once said that he thought urinary endoscopy was perhaps the most underutilized endoscopic procedure we perform in dogs and cats. And so I think that's probably why he chose this topic. He's going to tell us about both transurethral as well as laparoscopic assisted techniques. Dr. McCarthy is a boarded surgeon in the Portland, Oregon area, working in private practice, incorporating endoscopy in his practice for the last 38 years. He's been the first to develop and report on many endoscopy procedures, and he has changed the way many of us practice veterinary medicine. He's lectured internationally as well as nationally, published many papers, and is the editor of the textbook Veterinary Endoscopy for the Small Animal Practitioner. And the second edition will be coming out shortly, I believe. And so with that, I'd like to turn it over to Dr. McCarthy.
I'd like to say hello to all my friends around the world, and I hope that this presentation is helpful to you, and I am more than happy to answer any questions during the presentation or afterwards. Well, I don't have my email address on here, but anyway, yeah, feel free to contact me, and I'm happy to answer any questions. And as Dave said, I'm going to talk about interventional endoscopy and my experience in that field. And one of the things I encourage all of you to do is every day when you go to work, ask yourself, what can I fix with my scope today? The mindset of looking for a scope to use is huge in applying these procedures. If you don't think of them, they won't be included in your armamentarium. And when we started doing cystoscopy, it was primarily a diagnostic procedure and has expanded to include interventional and corrective procedures. And the indication for cystoscopy is anytime we need more information than can be obtained with a less invasive technique. As Dave said, I feel that cystoscopy is very, very underutilized. And it's also one of the easier procedures to perform, so there's no good reason not to be using this every day in your practice. With time, we started learning to correct procedures and develop the concept of interventional cystoscopy with basically, the same indications, but the bottom line is that anytime we have a lower urinary tract disease that's not completely resolved medically, interventional cystoscopy is indicated. And at that point, we should be doing diagnostic cystoscopy. And if we're prepared, then we immediately transition to a therapeutic mode if it's indicated. And the more I do, the more I feel that open surgery for lower urinary tract disease is an obsolete approach. My experience, as Dave mentioned, goes back 38 years, back into the dark ages. And you can see that most of the procedures I have performed have been transurethral. And then over time, we've developed various approaches other than using the urethra to allow us to approach and treat almost all the diseases we see in the lower urinary tract. The thing that's interesting is that percutaneous cystoscopy was the first way that I applied cystoscopy. I was doing a cystocentesis in a dog, and I thought, gee, if we had a really small scope, we could just do the same thing. And then found a picture in a human catalog of a 10 millimeter scope being put suprapubically through the skin into the bladder, and tried that. And then we've developed these other techniques to allow us to approach the urinary tract. In looking at selecting which technique we're going to use, it basically, we do everything we can transurethral. The only time we proceed to one of these other more complex, involved techniques requiring full aseptic technique is if we cannot get the job done transurethral. And whether you use the percutaneous type technique or lap-assisted, or many people use kind of a hybrid between these two without using a laparoscope, but bringing the bladder up to the abdominal wall by distending it and then making a small incision and incising into the bladder. And, you know, it doesn't matter which one of these you use, they're all work effectively. And then the perineal percutaneous technique is indicated in male dogs, that it gives us the kind of access that we have with transurethral cystoscopy in females, but C-arm is required. And if you don't have that, then lap-assisted or prepubic techniques will allow you to do everything in male dogs that we need to do. Instrumentation, most of what we use are rigid telescopes. The one at the bottom here is a 9.5 French one-piece scope, which is ideal for female cats, very, very small female dogs, and male cats during or after a perineal urethrostomy surgery. The middle one is their 2.7 scope, the standard multi-purpose rigid telescope with a cystoscopy sheath on it. And the top one is a standard 4 millimeter, 30 centimeter long cystoscope. And then for male dogs, we have this beautiful video flexible scope that gives an image that matches that of video gastroscopes. And it's 8.5 French diameter. The thing that's really interesting is that in male dogs, there is no correlation between dog size and urethral size. I've been able to get this in a 3.5 kilogram dog, and there are other 30 kilogram dogs I can't get it in because the urethra is too small. Then we have the 1 millimeter scope that is applicable for cats that have not had male cats that have not had a perineal urethrostomy. A new addition to this, it's been around in the human field for quite a while, but that's a continuous flow cystoscope. The previous ones, you can either have inflow or outflow, but you can't have both going at the same time. This system allows you to have inflow and outflow going at the same time so that you can maintain a clear visual field during complex or time-consuming procedures, and this is a real asset. This system fits the 4 millimeter cystoscope, and there's a 2 millimeter cystoscope that has the same system for smaller patients. Then in addition to scopes, and of course we need the video tower and all of it that goes with that, but we have a set of hand instruments, graspers, biopsy forceps, stone basket, a cytology brush, and I don't have a polypectomy snare on here. And then we have balloon dilation catheters and stents that we can use for various treatment procedures. Up at the top here, we have two lasers. This is the laser that I have. It's a 30-watt diode laser, and is the thing that really allowed me to get started with many of the interventional procedures that we do today. As an alternative, if you have this particular therapeutic laser, it has a surgical attachment so that you can use this to do almost all of the things we need to do in the lower urinary tract. It only has 15 watts of power, but that's enough for many, many of the things that we do. Another new addition is bipolar radiofrequency, and this may replace the laser in many areas of what we do, because we can cut and ablate tissue with this, and sometimes more effectively than we can with the laser. So this is certainly an alternative. The other advantage of this system is that you can use this as your standard surgical cautery, and have it available with for your bipolar endoscopy work. Now, to look at the different areas of involvement with interventional endoscopy, and I've listed these in the order of how common they are. And many of the parts of inflammatory disease we don't treat with a scope because it's just inflammation and we get biopsies, but there are situations where this becomes very important. And one of these is your urachal diverticulum. These are very, very common. I think they're probably more than 50% of the bladders I look in have some type of a diverticulum. And you can see this little indentation right there. That's the diverticulum. Here we've got a laser fiber coming in to ablate that, and this is after completion of the ablation. And these are anitis for recurrent urinary tract infections. And here we are, a short video of ablating this. And this is one of the very rare situations where we use a diode laser in a non-contact mode. Most of the time we're using it in contact with the tissues. The other thing we find in inflammatory disease are polyps, and these are very common. And we can remove them with a polypectomy snare. And in this particular case, we've got the snare around the base of it, and we just squeeze the snare and it cuts it off. This is doing it without cautery. If you have cautery available, and monopolar is plenty for doing this, we do the same thing. Here we've got a polyp. We put the snare around it, and as we squeeze, we activate the cautery, and it cuts and seals this while we proceed. We can also use the laser to cut the base. This is a large polyp here, and we cut the base off, and here's it after it's cut off, and then take this out of the bladder. And here we use continuous mode for most of the procedures we do with this, and we have this set at 20 watts. If you had a 15-watt laser, 15 watts would get the job done just fine. And an operative tip in these cases, we need to roll the patient so that the polyp is hanging from the top of the bladder, not dorsal or ventral positioning, but from the top in the position the patient's in, so that the polyp hangs down away from the bladder wall, rather than having it sit at the bottom where it's much, much harder to do this procedure. We can also use the laser to ablate. These are small polyps here, and we can just vaporize the polyps to resect them. And here's an example of doing that with a laser. And you can do this, you can see this is pretty quick. We can do a lot of procedures or a lot of polyps in a very short period of time to decrease the amount of inflammation that's present. And an interesting thing, this is an unusual case, had polyps, went back at a later time, and this had become a transitional cell carcinoma. And fortunately, we had histopath at this point, and we had histopath at this point, and this is a very unusual situation. I don't know if anybody else has documented this, but it raises the question, to be concerned about this. And I'd be happy to take any questions about management of inflammatory disease at this point in time.
Tim, I just have one question, and that is, after cutting big polyps, how do you remove them? Do you do a cystotomy to remove that, or how do you remove them?
I've only had one case that I've had to do an open procedure to remove. All the others, they're pretty soft and flexible, and I use either a stone basket, or sometimes after I've cut the base of it off with the polypectomy snare, I'm able to just grab it with the polypectomy snare and pull it out through the urethra.
How concerned should I be to damage the bladder wall while using the laser to ablate polyps or diverticula?
It certainly is a concern. I've not had a problem with that. The only place I've even gotten close to that concern is trying to remove extensive urethral transitional cell carcinomas. But it's just like any other piece of equipment. We need to be careful. We need to watch what we're doing. And fortunately, the scope allows us to see well. But I have not had any issues with penetrating the bladder during any one of these procedures.
Okay, that's it for now.
Okay, next we'll talk about tumors. And unfortunately, neoplasia is the second most common diagnosis that I make with cystoscopy. These are all too common. And bladder masses, to me, are a transitional cell carcinoma until proven otherwise. And we talked about polyps and the possible transition to those, but if you see a mass on an ultrasound, you know, we have to get biopsies of it to prove what it is. And other tumors have been seen in the bladder, but they're rare. You know, they're documented but not defined. And this is a leiomyosarcoma of the bladder and a small cell lymphoma in the bladder, just as examples of that. But most of the bladder masses that we see are transitional cell carcinomas. And in looking at some of the data for transitional cell carcinomas in dogs, one publication talked about it being 2% of all canine malignancies. And looking at dogs presented to a veterinary medical teaching hospital in 2014, it was 0.7% of all admissions, but this has increased from 0.03 in 1975. So over a 35 period of time, it almost tripled in the percentage of, no, that's, yeah, 30 times. So it's becoming more common. And of course, the question is this because we have more tumors or we're doing more diagnoses? But I definitely think part of it is that we just have more tumors. And one of the things that's really of concern is in Scottish Terriers, somewhere between 12 and 20% of Scottish Terriers die from bladder cancer. And they're the poster child for studying this disease. And there are other breeds that are seen more commonly, mixed breed dogs with an incidence of 1. You can see that Scottish Terriers, it's 21, and down several of these other breeds that we see. And when we compare transitional cell carcinoma in people, which is now called urothelial carcinoma, 80% of them are diagnosed as superficial disease in people. This is because when, if you go and have a urinalysis and there's occult hematuria, you get scoped. You don't pass go, you don't collect $200, you don't get ultrasound and anything else, you get scoped. And this is the gold standard for diagnosing TCC in human medicine. And we need to strongly consider that in our patients because our data is really, really bad. Okay, we diagnose 2% of transitional cell carcinomas as superficial disease. The other 98% were too late. So we need to find some way to diagnose this disease early enough that we can actually help these patients. This is unfortunately the typical cystoscopy with transitional cell carcinoma. This is the vaginal vestibule. All of these little fingers are transitional cell carcinoma. Another view in the vaginal vestibule. There is no recognizable normal mucosa. This is up past the cingulum in the vaginal body. This is the distal urethra, proximal urethra, and the bladder. So this is totally beyond any reasonable approach to effective treatment. And this is a video of scoping this same dog, and you can just see the extent of this. And this dog presented with an acute onset of urinary tract symptoms. So this has not been going on forever, but this dog had progressed to this point before it was presented any signs for the client to bring it in to have it looked at. And it's just the whole vaginal body and urethra were completely covered by transitional cell carcinoma. Okay, now why is this so difficult in dogs? And I think this last case exemplifies that. We don't see any symptoms until the disease is extremely progressed and is extensive and invasive. And when they do show symptoms, they mimic cystitis. And many times these dogs get treated for a long time before anything beyond antibiotic treatment is carried out. And we just treat symptoms. We hardly finding anything on physical exam unusual. You know, we can see sometimes, you know, reactive type cells on urinalysis, but that's usually not helpful. Ultrasound is the standard of care at this time, but the problem is that sometimes we need to find these when they're too small to show up on ultrasound. There have been a couple of tests to try to diagnose this earlier, the bladder tumor antigen test, which is very inaccurate. The newer test, the BRAF mutation detection assay, we do not know how big a tumor has to be before it can be picked up by this test. And this is something that needs to be looked at. And back to this, cystoscopy is drastically underutilized in managing this disease. This is when we need to diagnose these. And this is a really interesting case because this dog presented for a vaginal discharge. It was a 10-year-old West Highland White Terrier. We scoped it, did vaginoscopy. There was no foreign body. The owner insisted that it was a vaginal foreign body. There was a cervical discharge, and I think this dog had an ovarian remnant, but the client did not want to go in that direction. And while I had the scope in the vaginal cavity, I just happened to see the urethral orifice and popped into the urethra and up into the bladder. And here is a transitional cell carcinoma in that dog. And that is about 2 millimeters across there. And this also shows the advantage of the 30-degree angle of the scope, because this is looking directly down on top of the tumor. And this has the scope rotated the other way to show how much easier it is to see with that positioning. And in this patient, I biopsied that lesion, so we had a confirmation that it was a transitional cell carcinoma, and then painted the base of it with the laser to try to eliminate the tumor. We scoped this dog again in 12 weeks. There was no recurrent tumor. At 11 months, it was starting to come back, but it was about the size at our first diagnosis, ablated again with the laser. At 18 months, we were tumor-free. We scoped it again, and this is how these are managed in people. They are repeatedly scoped, typically every 6 months, to check for lesions and treat it. And so we, again, biopsied it, ablated it with a laser. And then out at 27 months, we were starting to come back again. But this is over 2 years, and we're basically the same place we are when we started. And we never have the opportunity to see that with transitional cell carcinomas. And then the client decided, since it was kind of showing up after a year, that she would wait a year rather than 6 months. Well, a year turned into 17 months, and she came back with about 1.5 centimeter diameter mass, which we resected with a laser. And then we went back 90 days after that, and it had spread all over the urethra, bladder, and was basically beyond the point where we could help. But we're out at 4 years here. And that's beyond what we typically see. I didn't see the dog after that, but I did get a report on this dog's 14th birthday. She'd had radiation therapy in this interim, and the dog, okay, is doing well according to her, seemed to be happy, except was urinating frequently. And this is our little friend here, really great little dog. So we got this dog out beyond 5 years, which is amazing. With other size lesions that we see, where we see actually defined lesions that have not taken over the whole bladder, with small lesions, and this is in the bladder looking transurethral, and we've got the laser fiber here. We ablate this, just vaporize it, trying to get down into the mucosa. And this is a 13-year-old male, I can't remember the breed, mixed breed dog, with a large mass at the apex of the bladder, which we removed surgically. Then we looked in the urethra and examined the rest of the bladder, and these are transitional cell carcinoma lesions in the pelvic urethra, and we ablated this with the laser. And this dog was probably the most unhappy dog I'd ever seen before surgery, and with the removal of the mass and getting rid of these lesions in the urethra, this guy went home and had at least a year of really normal, happy activity. So it was a real benefit for this case. The other thing that I found is with larger lesions like this transitional cell carcinoma mass right here, trying to ablate that or vaporize it all with a laser is not productive. It takes way too long and is really not effective. So with larger lesions, we want to transect them off of the base. And again, here we've rotated this patient so that the mass is at the top of the bladder, and we cut the base of it off with a laser, trying to, again, get into the superficial mucosa so that we get rid of any residual tumor. Another case right here, this is right in the trigone, and we've cut the base of this mass off right here, and basically eliminated the tumor in this patient. And here's another case. This is approach with a lap-assisted technique coming from the cranial aspect, and this is a large transitional cell carcinoma mass that is right in the trigone of the bladder, and we can see this is a urinary catheter coming through right here, and we move this around to look at the ureteral opening, so we can see one, and here's the other one. So the tumor is not close to either one of those. And in this case, we used a polypectomy snare with cautery and resected that mass. And then here it is floating free in the bladder. And in this case, since we're lap assisted and we can get rigid instruments in there, I just reached in with a grasping forceps and pulled this out. And if you were to get a mass that you resected transurethral and then it was too big to get out through the urethra, if that occurs, then lap-assisted approach is the way to go at that to get it and avoid an open surgery. Okay, how can we diagnose transitional cell carcinoma earlier? I mean, what can we do that's reasonable and practical? Our standard of care now is ultrasound. And the question is, how big does the tumor need to be able to see it with ultrasound? And are we too late? but this is a reasonable cost, doesn't require anesthesia. So this is kind of where we are now. The antigen testing is too inaccurate. It's just not worth even bothering with. Genetic testing, again, the question is, how big does the tumor need to be positive, and can we diagnose these early enough with this technique? And so we need more information on that, but it's the best thing we have available now that gives us a more, hopefully more accurate answer. But cystoscopy is the real reason, the way to do this. And it's the standard of care in human medicine. But if we look at doing this as a freestanding surgical procedure, it becomes excessively expensive, and a lot of clients won't go for that. But the answer is to do cystoscopy when a susceptible patient is under anesthesia for another procedure. I mean, a lot of dogs get dentistries once a year. If they're a susceptible species or susceptible breed, then we should scope while they're under anesthesia. I mean, it literally, I mean, the cost is minimal for the benefits that we may be able to achieve with that approach. Questions about tumors and transitional cell carcinomas in particular?
Yeah, we've got a couple of questions. One is a procedural question. What is the usual position you would put a female dog in doing cystoscopy? And then also, what would you use to insufflate the urethra, the urinary bladder, and so forth? And what solution would you use?
The position that I use lateral recumbency to start with. I know this is different than a lot of people, but you put a dog under anesthesia, they have a tendency to fall over on their side, and that's just how I started doing it, and I found that it works very well. People that have learned from MDs put them in dorsal recumbency. A lot of people put them in ventral recumbency because then you know, everything is anatomically aligned. It doesn't matter. With is it will work. And the solution I use, the distension, you know, 99% of the time I use physiologic saline and just a continuous drip flowing into the scope. And occasionally, and there are a couple of these pictures that are taken through air, I occasionally use air, but that is pretty much confined to those cases where I cannot get a clear field through saline.
Okay. Do you ever use any other palliative things with your bladder carcinomas, such as piroxicam or non-steroidals?
Yeah, they're all, I mean, yeah, medical treatment is part of the protocol, and it depends on the patient, the client, and the support services. Most of these I do in conjunction with an oncologist or an internist, and so they do the medical management typically. Piroxicam I've used a lot. That particular patient that made it out 5 years. This was a rather interesting client. She had it on Rick Simpson oil, which is a marijuana derivative. The dog did have some liver issues, so we didn't want to use piroxicam. But there are a lot of medical options that can be added to this protocol.
Okay. What are your chances of stricture with urethral surgery?
That's one of the problems, and I've over time, I've become less aggressive with trying to remove extensive urethral transitional cell carcinomas because stricture can be an issue. And you know, like that one Scottish Terrier that had basically tumor everywhere. To me, that's beyond helping with interventional cystoscopy or surgery. I have put in some stents. One of the things that I have found is if you do a lot of laser ablation in the urethra and you get a stricture, the tendency is that the stricture is going to invade the stent and close off the stent. So my preference at this point is if I'm going to put in a stent, I'm going to do it as a first step procedure rather than doing extensive resection in the urethra and then putting in a stent.
Okay. We have time for maybe one more question. Have you used holmium YAG lasers for ablation?
I do not have a holmium YAG laser, so I have not used that. And since I haven't used it, I can't really comment on, but my understanding is that with the continuous mode with that laser, it also works well for these soft tissue procedures.
Okay, I think that's it for now.
Okay, the other common thing that we see that we manage where interventional cystoscopy is a huge asset, and that is bladder stones. And we see all sizes, shapes, descriptions of, and locations of stones. This right here is an early on case, a male dog, and I got all these out transurethral with a stone basket. And that was only because the client refused a lap-assisted approach to that. And we can do approaches transurethral, and if the stone is small enough to come out through the urethra, then that is our preferred step. And here's a calcium oxalate stone with a stone basket, and then we just take this out through the urethra. If the stone is too big to fit through the urethra, you do not want to try to force it to come through because it may get stuck. You may tear the urethra or damage it and end up causing a stricture or other problems. One of the other things that you can do is with sand, and this is very fine sand here, you can just vacuum it out with the scope. You fill the bladder up, turn your outflow on, and just suck all the sand out, and that can be highly effective. And I don't use hydropropulsion commonly, but in female dogs and cats with a whole sandbox in their bladder, this can be a very effective technique. I use it in combination with a scope. Number one, to see, okay, are all these small enough to come out through the urethra? And then it may take more than one hydropropulsion to get all the stones out. And you start with a whole bunch, and this is after we've gotten some of it out, and this is after this was removed and we've got one left that we makes you very effective, but using the scope with it makes it so you can really tell how effective you've been. And I have not done hydropropulsion in male dogs, but Jody Lolich says that that is doable. So, but I have not tried that. Now, these stones are not removable with transurethral cystoscopy. Now, if you have a holmium laser, you can break these stones up, but this is a male dog, and taking out hundreds of little pieces would be excessively time consuming. So my approach to this is to do lap-assisted cystoscopy and remove all of the big stones and all of the little stones, and is a very effective technique. And what we do, you do laparoscopy, you pick up the bladder, pull it up, make a small incision in the bladder, enlarge your portal here. And if you're doing something simple, I just put in a couple of stay sutures. In a situation like this where you've got lots of stones to remove, I just suture the bladder wall to the skin very quickly so we don't lose any of these stones into the abdomen. We use forceps to remove the large stones, and we can use aspiration to and here we're using a stone basket. So any technique to grab the stones with. And here we are using the biopsy forceps, but it was just the thing I grabbed first, and it worked very well for picking these up and taking out stones. Graspers, you can use stone baskets, but with this approach, any kind of grasper like that works well. When we have a whole bunch of stones like this that are small, okay, you can go in with a grasper and grab them one by one. Sometimes you get more than one together. But here we're just passing a suction tip, standard open surgical suction tip beside the scope into the lap, using lap-assisted approach, and basically vacuuming all of these stones out. The trick with this is to have enough suction to pick up the stones, but not so much that we collapse the bladder and can't see. So this does take a little bit of time to manipulate and pick up all the stones and get them all out. And you can also see that we can get down into the urethra to make sure that we don't leave any, excuse me, stones in place. And I think if somebody does the right study and takes and looks at doing stone removal with traditional open surgery, we will find that close to 100% of urethras, because you really can't see these small stones very well. And this takes a little bit of time. You can see, watching it on the video, it's come on, get it done, get it done. But when you're doing this, this actually is pretty quick. This is unedited, so it's real time. And by the time you try to get this out without using this technique, it's going to take way longer, and you aren't going to be able to be sure that you got all your stones out. And if you end up with a couple of stones that are a little bit bigger that you can't get through the suction tip, yeah, then you just put a grasper in and get those. But this is far quicker than trying to pick each one up with a grasping forceps. But you can see there we've got, and there goes the last one. So we were able to get all of those stones out, and the tissue you saw a little view of up here is an inflammatory polyp that is commonly seen with stones. Another place we use hydropropulsion is in stones that are stuck in the urethra of male dogs, and this is a well embedded stone, and we use a scope with this so that we can see the stone in the bladder. We hydropropulse it back into the bladder, and then we do lap-assisted technique to get the stone out. And here we've gotten it moved a little bit, and here you can see that it's been out of its embedded position. And since I learned how to do this, I have not had to do a urethrotomy in probably 25 years. I've been able to get them all blown back into the bladder. It does take full anesthesia. Sedation is not enough, and it takes pretty good force sometimes, but this does work, and then we don't have to worry about urethral strictures. Although we do have to worry about urethral strictures, but not from surgery. And this is that case that I just showed you, and this is one that would concern me about a possible stricture, but there is a pretty good stretch of normal mucosa on this side up here, so that's not likely. This is a stricture later on, not in this case, but in another case. And in this one right here, okay, there was a stone lodged here. We hydropropulsed it, and there's mucosal damage right here, but the majority of the circumference where the stone was stuck, the urethra is normal in appearance. So this patient has a low likelihood of stricture. I would not do anything to manage it. This patient has a higher incidence. So we need to be concerned about that. And then if we get a stricture, and this is due to a different cause, this is unfortunately doing a prostatectomy when trying to do a cryptorhodectomy in this paper reported in 4 dogs. There are multiple publications out there listing this as a complication of cryptorchid surgery. The solution to that is to do laparoscopic cryptorhodectomies, or make a full-length abdominal incision, and they'll try to do it through a spay incision. Anyway, this patient presented with a stricture, and unfortunately I touched the stricture with my scope before I got a picture. So there's bleeding here. This was about 1 millimeter in diameter, passed a balloon dilation catheter and dilated that. Commonly, these will require multiple dilations for correction, but this one, it was solved with 1 dilation, and so we were able to do that successfully. Stents are an indication in a situation like this if you have a recurrent stricture. Questions?
Yeah, we have a couple of questions. One was, oftentimes dealing with esophageal strictures, people will inject triamcinolone. Have you done anything like that with your urethral strictures?
That's certainly a possibility. I haven't needed to, but yes, that's certainly one of the approaches that can be used. And there's some other drugs that are used in those situations too. But certainly if you're concerned about a stricture forming, doing it at the time of your hydropropulsion would certainly be indicated, because the patient's already under anesthesia and you've got the scope there ready to go.
Another question is, when you're doing transabdominal cystoscopy, how do you manage the patient post-operatively? Do you have a urinary catheter in? How long do you keep it in? Things such as that.
I put a urinary catheter in and leave it overnight, preferably about 24 hours. I don't, when I close the bladder, I do not use any mucosal sutures. I close the seromuscular layer and submucosa. And I want that mucosal layer to seal. There's also a study done in quite a few years ago where looking at the strength of cystotomies, and they found that after 24 hours, if you blew a bladder up to rupture it, it would rupture through someplace other than the incision. So that has been my protocol. Whether that's totally necessary or not, I don't know, but that's been the protocol that I use.
Okay, there's another question, of which I also have a question, is I've had some dogs with urethral transitional cell carcinomas, and it was very extensive, and I wanted to just try to palliate the patient so it could urinate to buy a little bit of time. And how do you prevent damaging full thickness of the urethra?
That can be difficult, because you cannot see any of your layers that you can use to gauge how deep to go. I've done something that, again, I haven't done enough cases to really be able to get a good handle on its efficacy and how long it lasts, but I've used balloon dilation in some of these really bad cases where I don't really remove any tumor. I just dilate the urethra with a balloon, and it allows some of these dogs to urinate. And particularly if I'm measuring for a stent and I have to order a stent, I'll do a balloon dilation at my first cystoscopy and then go back in and put a stent in place.
Okay. I've got another question. Sometimes they find multiple calculi right before the os penis and they're difficult to get back with hydropulsion, how would you deal with something like that?
Well, as I said previously, since I started doing hydropropulsion, I have not had a case where I couldn't hydropropulse them back into the bladder. I know that that is certainly a situation that it can occur. Back before I was good at hydropropulsion, I actually used a small rigid scope, my little 2.7 scope, in the distal urethra of a large dog, and literally very gently pushed the stone out of the position it was lodged in, and then was able to hydropropulse it back into the bladder. From one standpoint, I hate to mention that because you can damage the end of your scope, so you have to be very, very careful. But if you're really stuck and can't get it to do anything else, that is certainly one of the things that you can do. And if all else fails, we do urethrotomies to get these stones out. So if that's what you have to do, that's what you have to do.
Yeah, I also think a key to hydropulsion is to have your patient completely anesthetized, where they're completely relaxed, and that will improve your ability to do hydropulsion, just kind of from my experience.
Yep, absolutely. And I've seen multiple patients where the referring doctor has used sedation, not anesthesia, and was not able to get the job done. And when I fully anesthetized the patient, I was able to get the job done. So that is a really critical issue.
Do you ever use flexible scopes for cystoscopy in female dogs, or is it always rigid?
I always use rigid. It's just so much easier to do. The rigid scope allows you to push the tissue around where you need it. I mean, if I only had a flexible scope, I would certainly try it, but I have not used that, so I don't really have any experience in it.
Okay. Do you have more to go, or
Yes,
why don't you continue on?
I have one more section.
Yeah, continue on.
Okay. Okay, the other one, anatomic abnormalities, and this is primarily ectopic ureters, and is, again, one of the big advances we've been able to make in applying interventional endoscopy. The other abnormality I see, and this is extremely common, are these vaginal webs. There are multiple ways that we can cut these, but I make it a routine practice to cut these whenever I scope a dog and see one. And that's because of this particular patient right here. This dog was incontinent, came in, it was a young dog, came in for cystoscopy to confirm or find a diagnosis of ectopic ureters. The dog was anatomically completely normal other than this vaginal web. I cut the vaginal web and the dog went home continent. So I never leave these uncut. I can't say that cutting this is going to fix incontinence in a dog, but in that particular patient it did. Some of these really fine ones right here, you just simply push against it with the scope and it tears and you're done. That's really easy. Here I'm using a small 5 French scissor through the scope, a biopsy channel. That works very nicely if you have one of those. Here I'm using a laser. For one this size, I would not typically use a laser, but this dog also had an ectopic ureter, so I was going to use the laser for that. Here I'm using a biopsy forceps. They work really well. And this is a really old case right here, and I'm using the scope to align a pair of Metzabom scissors to cut a vaginal web. So any way that you can cut these works really well. If you have radiofrequency, bipolar or monopolar, you can cut it with that. And here's using a biopsy forceps to divide this patient right here, and very easy. That one would probably just, you could push the scope against and do that one very nicely. And the big reason for doing this is for ectopic ureters. And diagnosing ectopic ureters, the only way to diagnose ectopic ureters is with a scope. I still find cases where I'm called in to do an ectopic ureter and they have it defined with contrast CT and all kinds of other things. And what I find with a scope is not what was the preoperative diagnosis. But here we have, two that are just fairly close to the trigone, but in the urethra, they're too close together. Here's some that are in the urethra, but they're anatomically pretty normal looking. Here's a much more abnormal one with a large opening, and you can see the ureter in the wall of the urethra going all the way up into the bladder. And this is the case that started the concept of transurethral correction of ectopic ureters. And an 8-week-old lab puppy that was just leaking urine continuously, that did urinate normally when taken outside. And this dog was a walking lake. I mean, you could swim in the examining room after this dog was in there for a little while. Completely normal on pre-anesthetic workup, except indication of a urinary tract infection. And this is the scope examination. This is the opening of the left ureter right inside the urethral orifice. So this runs the full length of the urethra. This is the other ureter here, the left one, and that is in a total normal, or the right one in a normal and anatomically in normal location. And this conversation that I had with this client, I've done in innumerable cases to try when I'm trying something new that either hasn't been done or I've never done before. But talking to the client ahead of time about, I'd like to try to correct this with a laser if this is an appropriate case. I told her never been done before. And if I get in there and find out I can't do it with the laser, then I will convert and do a traditional approach. And it's going to cost her the same no matter what I do it. And I've probably done this hundreds of times, and I've never had a client say, no, I don't want you to do that. It's amazing how excited and cooperative they are to find a better way to do things. Anyway, in this particular patient, used the laser at 10 watts, continuous wave with a 600 micron fiber, and just cut that free wall of the ureter all the way up into the bladder. So we're at the level of the normally placed ureteral open. Okay, and this took me 5 minutes, and it worked. And this is where this started. This dog went home dry, was dry at its 2-month recheck, still dry at 6 months, had an ovariohysterectomy performed, and then was dry when the owner remembered to give it phenylpropanolamine, but it wasn't a big enough issue where she even remembered to give the medication. And then I was able to check with this dog at 3 years, and it was completely dry on phenylpropanolamine. So this is what got this started. And I've done, I went back. We can also do this in male dogs. Ectopic ureters in male dogs are relatively uncommon. And here's an ultrasound of this 1-year-old black lab, male black lab. And this is a dilated ureter right here. This is actually your ureterocele. And here we have showing flow of urine out of that into the bladder. And this is far enough caudally that it's significant. Urinary incontinence while sleeping. urinates normally when outside, has recurrent UTIs, which is a common finding in male dogs with ectopic ureters, totally normal otherwise. Now, some people can do this through the urethra with a flexible scope. I have not been able to do that. I'm not good enough to do that, or I just haven't been stubborn enough to try it. So I did a laparoscopic approach to this and used a monopolar radiofrequency resectoscope system that I had and modified the electrode. The electrode comes as a right angle. I bent it so that it made a little bit of a hook, and here it is sticking out of the sheath on the scope, and this is the resectoscope sheath here. And in scoping this, there's a little bump here that looks like it has a hole in it, and another one back there, and the opening of the ureter is back there, and this is the pelvic urethra. Here we can see the urine coming out of that tiny little hole, and confirms where our opening is. And so we use this, remember, we're coming from cranially now, so we're looking caudally, and this is that resectoscope wire here, and it's bent so that it hooks back. It fit into that tiny little hole very nicely. I was able to use it to lift up the free wall and then use cautery to cut that. And here we are with it completed. Dog went home with no incontinence, urinated normally, no UTIs, and when it was rechecked, was normal on physical exam, and behavior was completely normal. So if you can't get at it transurethral, a lap-assisted technique and approach works really well. If you look in the literature, they talk about ureteral seals being very uncommon. They're way more common than we think. In fact, most of the ectopic ureters we see are associated with ureteral seals. They're uncommon in a normally placed ureteral openings. And here, this is a ureteral seal. Here is just a large dilated ureter in the wall of the bladder. This is the contralateral normal ureteral opening. Here we fed a weasel wire up through the ectopic ureter, and I've got a laser here, and I'm cutting in this. Seeing these windows in the septum is also not uncommon, and here we're going to cut that little piece, and then we're going to go forward and cut forward until we see the ureter going out through the bladder wall. Sometimes I use a weasel wire or catheter in this kind of a situation. When they're this dilated, you don't always need to do that. And here just shows using the laser to cut the free wall. And this was a different patient where we used a red rubber catheter, and you just use the laser and cut the tissue, and you can see really well, and you can go all the way up to the level that the ureter should come through the bladder wall. And my experience with ectopic ureters, okay, I diagnosed the first ectopic ureter in 1984. Took me 20 years to figure out how to correct these transurethral, but I did the first correction in 2004. I tried several different techniques of cutting these, but without something to produce hemostasis, as soon as you make a little nick, you get enough bleeding you can't see. So until I had the laser, I wasn't able to do this. The radiofrequency system may replace the laser with the way things are looking now, but both work well. I've done 38 of these, 36 females and 2 males. All of the cases I've seen have been intramural ectopic ureters. So I know extramural ones occur, but I haven't seen one yet. I've had to reoperate 3 of them. for incomplete corrections. One was a urethral, where there was a large window, and then there was a caudal pouch that I missed. And I've had, the other two were vaginal, where, okay, these were intramural in the urethra and came down and then went over into the vagina to open. And so they're rather unusual. Complications have been rare. I mean, continued incontinence isn't really a complication because the anatomy is more than just the ureter being wrong. The sphincter is not necessarily formed properly. So that's just part of the disease process. Recurrent urinary tract infections have been uncommon, but they do occur. The one of concern is stricture or occlusion of the neostoma with hydroureter and hydronephrosis. And I've seen one case of this, 5-month-old golden retriever presented with standard ectopic ureter symptoms, and ultrasound was suspicious of ectopic ureters. And we did a correction. And this dog had, okay, these ureters are not dilated, so they're small, and they're too close together, and they're just caudally into the urethra. And in these, I do pass a weasel wire because it's sometimes very difficult to follow the lumen, and we cut these back up to a normal location. But the problem is that this opening is really small. It's not dilated like we see with the ureteroseals. And I saw this dog 18 months later. It was depressed, vomiting, and it had been continent, hadn't had any urinary tract infections, but this was a sick puppy. And ultrasound showed that the right kidney was hydronephrotic. We had a dilated right ureter, and there was perirenal fluid. So this was a really bad case. On cystoscopy, this is the open functioning ureter, and this is the occluded right ureter. The opening is completely closed off and obstructed urine flow. And I think if we caught these early enough, we could open this and correct the problem. But in this case, the client requested nephrectomy, didn't want to do any attempt to salvage the kidney. And in this case, it probably was too late anyway. And okay, the question is, what cases, I mean, this is the only one I've seen. I've talked to a couple of other people that have seen this. So what cases are at risk? And how can we monitor these patients to catch this early enough that a simple, opening of the closure here is going to correct the problem? And I mean, ultrasound is the thing that makes the most sense. It's easy, but what interval? And I don't have the answer for this. I have the question. I think if we do one of these ones with a really narrow ureter, maybe we should be ultrasounding those at intervals to see if they function normally or if they develop a problem. Any questions about these?
Yeah, Tim, I think we're good. I think you answered pretty much all the questions. So I would like to thank you very much for this great presentation, and to remind everybody that this video will be available online at endoscopytalks.com, and that's free to anyone. Also, next week, our speaker is Dr. Bol Franson from Washington State University, and she will be talking to us about starting laparoscopic suturing technique. She's a real leader in minimally invasive surgical procedures, and she will talk to us about that. And that will be next week, Wednesday, August 26th at 8 p.m. Eastern Daylight Time. That's New York time. So anyway, wishing you all well in your practice, and of course, best health to everyone. And we hope to see you again next week. Thanks a lot.